Good evening, everybody. I'm Ben Goff. I'm one of the members of the committee here, so I want to thank you all for joining us tonight. We're very lucky to have Dr. Nicole Saur here with us tonight, and I'll do a quick introduction for her. Dr. Nicole Saur is Assistant Professor of Clinical Surgery at Penn Medicine in the Department of Colon and Rectal Surgery. She attended medical school at the University of North Dakota, followed by general surgery residency at Tufts New England Medical Center. She went on to complete her colon and rectal surgery fellowship at Cleveland Clinic, Florida. Dr. Saur is a minimally invasive surgeon with a special interest in advanced laparoscopic techniques. She has an interest in the optimization of patients for surgery, namely prehabilitation. In addition, she has a clinical and research interest in caring for geriatric patients and is leading the geriatric surgery initiatives at Pennsylvania Hospital. She is the chair of the Geriatric Task Force for the American Society of Colon and Rectal Surgeons. And tonight she's going to be talking to us about a roadmap for integrating geriatric optimization and patient-centered outcomes into your colorectal surgery practice. Dr. Nicole Saur.
Thank you guys so much for having me. It's really an honor to be here. I know when I was a fellow, we did not have anything like this. So I think that the initiative that you guys have taken to kind of broaden your education is really impressive. And I'm really happy to be here. As you said, we'll be talking about this roadmap to integrate our geriatric optimization. So I don't have any disclosures. Geriatric surgery doesn't come with a lot of funding, so just keep that in mind if you want to join us on our research efforts. But as a disclaimer, I just want to say I'm passionate about the care of geriatric surgical patients, but I did not know any of this when I was sitting in your seats as a fellow. So I think the field is evolving, but I think also the education that I had in my residency didn't include any of this. So I hope that this is something that you guys can take into your practices when you get started. It took me a little bit longer in my own practice. And this is a photograph of my grandfather who taught me a lot of what I know about life, but also a lot of what I know about end of life and what geriatric patients find to be important at the end of their life. So we've been seeing a lot about frailty versus age. This is in the literature, this is in the popular press, everybody's talking about it. And there are a lot of initiatives, luckily, where this is being addressed. But what exactly does that mean? So we can, as surgeons, do a decent, sometimes eyeball test on patients who are very frail. So this patient with oxygen, perhaps he's bedbound, that is not too difficult to do an eyeball test. But what about this patient? You know, maybe he's having some signs of anxiety or depression. Perhaps he's walking with a walking aid. What about this patient where she's getting some assistance at home, but perhaps is otherwise functional? And what about this patient, Betty White, who is at 99 pre-COVID, still working and acting and doing her job? She probably has some underlying vulnerabilities that aren't being addressed, but would become apparent if she were to undergo major surgery. And this is what we need to know. We can't be doing an eyeball test. We have to have some objective information to tell us which patients should be optimized. So that brings us to what is frailty. So it's an accumulation of deficits that results in an inability to tolerate stress. And of course, surgery is the optimal stress here. And it's also sort of roughly described as increased vulnerability. So anytime that the patient is more vulnerable, then they obviously have an increased risk of having problems from surgery. When we talk about phenotypic frailty, there's this frailty phenotype, also known as the Freed's criteria. And that's obviously more specific. It's 3 of 5 of the following traits. And this will become important because in one of the studies that we'll talk about later, they use this frailty phenotype as their differentiation between frail and fit. So it includes slow walking speed, impaired grip strength, self-report of declining activity levels, unintended weight loss, and exhaustion. And these are the things that we're going to be looking at with our frailty screening tools. So we did a publication recently in JCO looking at the multidimensional, multi-phase pathway to improve care in older patients. And I've sort of pivoted this into what we call PREP at Penn, which is perioperative evaluation and planning. And this is an incremental pathway that you can implement at any hospital. And it's multi-phase and multidimensional and multi-specialty. So just like ERAS, it has a preoperative phase, which includes frailty screening, prehabilitation, in cancer patients, of course, neoadjuvant treatment when appropriate. It also includes the very important shared decision-making. We'll talk about that a little bit more in the talk, but we of course need to be taking into account what the patient's wishes are at the beginning of the treatment pathway. And at the bottom, you can see the different specialties that are involved. So we have geriatrics, PTOT, med-onc, and rad-onc as always. And the big thing that we need to think about, and this is why we shouldn't be talking about age, but we should be talking about frailty, is we need to think about modifiable versus non-modifiable factors. So of course, frailty is potentially modifiable, age is not. So that's why we shouldn't be thinking about just age, and we should be thinking about frailty. Whenever we have a patient who's frail, we should have a frailty expert included in their multidisciplinary team. And this is something that we're lacking at a lot of tumor boards, to have a geriatrician, maybe a palliative care specialist, maybe the patient's own primary care doctor, to give their feedback on the patient's wishes, not necessarily from a surgeon's lens or an oncologist lens, but somebody looking at their whole picture. Then, of course, we have the intraoperative pathway, which includes minimally invasive surgery, and also enhanced recovery is sort of along the bottom. Initially, we had it within the intraoperative phase, but we all know that enhanced recovery is really a multi-phase pathway. And when I talk about geriatrics, a lot of times I talk about how it sort of mimics how we implement enhanced recovery. People weren't necessarily starting out just in implementing the entire ERAS protocol when they started, because it's difficult and it's costly. So you can start with a few interventions and then intervene on the entire bundle. And then postoperatively, we'll talk about geriatric co-management, which is incredibly important in these patients. Rehabilitation. When we talk about rehabilitation, a lot of times in surgery, we're talking about quote unquote discharge to rehab, not necessarily an active rehabilitation, which is a multimodality pathway, which includes the same things as prehabilitation. So exercise, nutrition, social support, etc. Then we have social support, any adjuvant treatment. And then in the big box at the end is functional recovery, because that's really what we're looking at. If we do a right colectomy and we give somebody a perfect right colon surgery, we take out 12 nodes and they have a perfect oncologic outcome, but they can't go back home or they can't get back to their normal functional status, then a lot of times in the patient's expectations, they haven't won, even though we've done a beautiful surgery. And so this is what we need to be defining up front so that we can make sure that we have shared goals and that we're meeting the patient's goals as well. So this talk will sort of incrementally follow how you can implement this pathway. So we'll start with things that people are hopefully already doing, and then things that can take a little bit more resources to enact. So first of all, we'll start with minimally invasive surgery. So a lot of people, especially those who don't do a lot of minimally invasive surgery, will tell you like, oh, minimally invasive surgery, it's too stressful for the patients when they're geriatric, and so therefore they shouldn't have it. But we've had a lot of systematic reviews and meta-analyses that have shown that the complication rate in laparoscopic surgery for older patients is actually lower than in open surgery. So you can see that in multiple systematic reviews. And the two randomized controlled trials that we have for minimally invasive surgery, one showed a benefit toward improved outcomes, including morbidity and mortality, and then one showed no difference. So nothing has shown a worsening outcome with minimally invasive surgery in older patients. So that is something to keep in mind as you're going through. We always talk about the stress of surgery, right? So when we talk about the stress of surgery, we should be thinking about the entire perioperative period, not just the surgical time itself. So yes, minimally invasive surgery potentially could be more stressful with the venous return with pneumoperitoneum, and potentially can take longer than open surgery. So that potentially adds a little bit of stress as well. But then if you look at the entire perioperative period, if they have a midline laparotomy, they're going to have more stress on their body for the entirety of the perioperative period. And that potentially is going to cause more complications and decreased functional recovery. So we shouldn't be eliminating minimally invasive surgery just based on age alone. The thing I will say about all of these studies is that none of them looked at frailty. They only looked at age, but we know that we shouldn't be eliminating it based on age. The second thing is enhanced recovery. A lot of places, most places that are doing colorectal already have a really well-established enhanced recovery protocol. And so you can utilize this also in geriatric patients. So the key protocol items for geriatric patients are early mobilization and oral intake, early removal of urinary catheters, avoidance of NG tubes, and opioid-sparing analgesia, just like younger patients. There are some caveats though. In the analgesia portion, we should avoid gabapentin in older patients because it can cause dizziness, and especially when combined with narcotics, is associated with an increased risk of falls. There's a Beers criteria, which talks about medications to avoid in older patients, and gabapentin is on it. So even though it generally is in ERS protocols, we advise avoiding it in older patients. And also Toradol. So Toradol can be used in older patients, but not in patients who have a history of renal failure. So it should be used sparingly. And this is a population where you should definitely give an end date to the Toradol, so you don't give too many doses, or maybe even just give it on an as needed basis. There was another systematic review and meta-analysis looking at enhanced recovery in older patients with colorectal surgery. And they showed lower incidence of morbidity, shorter length of stay, and time to first flatus with ERS protocols. And there were no difference in ileus, readmissions, or mortality. So it is safe, but again, you should be thinking about the individual patient, and sometimes some variations are needed in those patients. There was a randomized control trial comparing enhanced recovery to standard care among 240 older adults, which was defined as greater than 70 with colorectal cancer. And they showed that there was a lower incidence of postoperative delirium in the enhanced recovery protocol. And then another one with 150 patients, also in colorectal surgery, showed independence preservation, which was home discharge, was higher in those with enhanced recovery. So again, we should be using the protocols that we have and just modifying them as needed. Next is frailty screening. So frailty screening should be something that we can all do in our offices, and that is differentiated from a comprehensive geriatric assessment or a geriatric assessment, which is done by a geriatrician or somebody with geriatrics expertise and can take 45 to 60 minutes. And generally speaking, we use frailty screening to determine which patients need a geriatric assessment. But we can be using this on all of our patients just to get an idea about really who needs to be seen by a geriatrician, especially when resources are scarce, and also to help you have a discussion with the patient about what their goals might be. So frailty screening should be brief. It should identify those in need of further evaluation by the comprehensive geriatric assessment. It should provide insight into the patient's general health, predict individual risk, and then allow interventions. Because if we're just identifying frailty, then we're not utilizing that it is potentially a modifiable risk factor. So this is a really interesting study, especially for me, because I run our colorectal cancer tumor board at Penn here. But they did a study where they looked at 20 cancer multidisciplinary tumor boards, and they discussed 71 people who were older than 70. And they found out that they were using a lot of non-specific descriptors like fit, well, and good to describe the non-cancer aspects of older people. And then they were modifying that with the very specific, very, pretty, and quite. And what happens is that when you do that, you end up using these non-objective, potentially ambiguous descriptors, and patients are having their treatment swayed by that. So patients who are older but potentially could undergo standard treatment maybe aren't because of their age. And those who are frail but potentially a bit younger are getting standard treatment, and perhaps they shouldn't be because of their frailty. So you wouldn't show up to a colorectal cancer MDT with a rectal cancer patient without bringing the MRI. And in the same way, we shouldn't be talking about these patients without having their frailty information addressed. And also, like we talked about, we should be including a frailty expert in the multidisciplinary discussion. So this is a consensus that we put together way back in 2017 with the European Society of Surgical Oncology, the European Society of Coloproctology, the International Society of Geriatric Oncology, and the ACS-COC. And we wanted to look at rectal cancer because, as you know, it's incredibly complicated. And then geriatric patients are also incredibly complicated. And so figuring out how to best manage these patients is very difficult. So we made a number of recommendations. But the interesting one, I think, for this talk is, again, talking about the multidisciplinary team. So we, again, should be talking about frailty and not age. We should be doing some kind of frailty screening, and I'll go through some examples. If frail, the patient, again, should be discussed with the geriatrician in the multidisciplinary team. And if the patient is fit, we should be treating them with algorithms developed for younger patients. We shouldn't be automatically altering their care just because of their age. So this is an example of the algorithm that we developed. So if the patient is 70 or greater or appears frail, then you can do these 4 frailty tests that we'll go into. And if any of them are abnormal, then they should get a geriatric assessment by a frailty expert. They should be involved in the multidisciplinary team. And potentially they should be getting adapted care if they're frail. So for example, maybe a colostomy instead of an LAR. And if they're fit, again, they should be treated with the usual care. either if that's determined with the frailty screening or after they see a geriatrician, if they find out that they don't have any risk factors, they can also be seen with the usual care. So we'll go into the 4 things that we discussed in our consensus, but again, you don't need to use these specific frailty tools. There are many, many frailty tools. There are many scores. Really, it's whatever is easiest for you and your team to implement. Is any of them are fine. Any frailty tool is better than no frailty tool. So some threshold to help the patient to determine what their best option should be. So one is the G8, which asks several questions. They looked at this in 143 patients undergoing cancer surgery. The sensitivity was 82%, the specificity 63%, and the negative predictive value was 85%. So patients with an impaired G8 had a prolonged length of stay, higher rates of delirium, and higher rates of mortality. The Preop study was a really interesting study looking at the timed up and go, which is a 2-meter walking test. So the patient sits in a chair, raises and walks 2 meters, sits back in the chair, and then you stop the timer. So if it's greater than 20 seconds, then that's abnormal, and less than 20 seconds is normal. So when they looked at this, comparing the complication rate with an abnormal timed up and go, or compared to the comprehensive geriatric assessment, which again takes 45 to 60 minutes to complete, they found that the complication rates were pretty similar. So major complications in the patients with a normal timed up and go is about 20%. That's pretty similar to the comprehensive geriatric assessment, which is normal. And then in the abnormal timed up and go, major complications was up to 60%. It's about 50% in the CGA. So it correlates pretty well to a really long test that can be kind of labor intensive. And so it's just a good way to understand somebody's walking ability. The mini-cog is a 3-word recall as well as a clock drawing. And that was also shown to be associated with frailty. So 44% impaired baseline cognition in one of the studies that they looked at with 168 patients undergoing elective surgery with a planned ICU admission. They had a higher incidence of complications if they had an impaired mini-cog. Of course, they had a higher incidence of delirium, longer hospital stay, increased institutionalization after discharge, and increased 6-month mortality. This is a study that I worked on called the Go Safe, and we'll go into that in more detail later on, looking at the functional recovery and quality of life aspects. But that stands for the Geriatric Oncology Surgical Assessment and Functional Recovery After Surgery. And this was early data that we just looked at the actual demographics of the patient as well as their frailty information. And something interesting that we found as a result of the study is that when we asked patients and their caregivers if they had a history of cognitive impairment, that was only identified in 12% of our cohort. But cognitive impairment was identified in 21% by the mini-cog. So we know that we're underreporting just by self-assessment patients who have a history of a cognitive impairment and then are at risk for delirium. And that can be really a devastating complication for patients because they are starting to have some kind of cognitive impairment. They don't know if it's going to be long-term or if it's just going to be transient related to the surgery. And if nobody did a mini-cog, then you can't tell them if they're going to have long-term problems. And that can be really devastating for them and also for their family. And so this simple test, any surgeon can do it. And it's something is relatively easy to translate into the postoperative period, but at least it gives you the baseline. This is one of my favorite publications ever. It's from JAMA Surg back in 2013, Jones et al., genius people who came up with this simple question, have you fallen? And they just asked patients if they'd fallen in the last 6 months. And that was associated with an increase of 1 or more postoperative complications. So if they had 1 fall, it was about 50-50, 2 falls, a little bit more than 60. But you can see if they had 3 or greater falls, they had a 100% chance of postoperative complications. So that's something we can be asking. A lot of times it's asked already in the electronic medical record. So it's something that you can look at with your patients. I will warn you, I did have one patient who said that he fell out of a wheelbarrow while cutting his trees. He was obviously incredibly fit. So you have to, of course, take the context in as well. But generally speaking, it's very effective in identifying patients at risk. So then we'll talk about prehabilitation, probably the most controversial part of the talk. And really, we could talk about prehabilitation for the next 3 hours, but I'll try to keep it sort of succinct and hopefully helpful for your future practices. So this is the big study out of JAMA Surgery, Carly, the grandfather of prehabilitation. comes in with this awesome randomized control trial looking at prehab versus rehab in patients with colorectal cancer. This is sort of our bread and butter. And they looked at 110 frail patients, which they defined by the Freed frailty criteria, like we talked about. They did intensive prehab versus rehab, and they really do intensive treatment. They do treadmill walking, they do measurement of the response, they do optimal nutrition, social support. So it's a really intensive program, either in the preoperative setting or in the postoperative setting. The mean age of the cohort was 78, and 79% of patients underwent minimally invasive surgery. And they, of course, have a really robust colorectal surgery team. So they also had a sort of perfect ERAS protocol where everybody was undergoing the ERAS interventions as well. And sort of shockingly, they found no difference between the groups. And then people said, well, you know, we're talking about complications, we're talking about length of stay, we're talking about readmissions, but actually they're talking also about functional recovery. They're also like recovery of walking capacity. They're talking about patient reported outcomes on quality of life, and there was no difference. And so then people said, okay, well, forget it. We don't need prehab, right? It's expensive. We don't really need it. It's not showing a difference. And I think we're sort of missing the point if we say that, because we know that this group had a high rate of minimally invasive surgery, a high rate of enhanced recovery. So patients were already being optimized, and they caught patients who were potentially at risk for complications post-op, and they put them through this intensive rehabilitation, not just rehabilitation as a discharge disposition, as we sometimes do in our pathways. So the people who believe in prehabilitation sort of said, well, wait a second, we don't think that this means that we shouldn't invest in prehabilitation, but we probably need to think about it a little bit differently. And one of the ways that we did that is that this group did a follow-up study in EJSO, and they looked at patients who were not able to be adequately prehabbed. And again, this sort of shows how good of a model they have, because they use this 6-minute walking distance, which requires a treadmill, which most of us can't do in our practices. And so that's why a lot of us are using this 2-meter timed up and go as a surrogate. But they looked at patients who couldn't achieve their sort of optimal walking distance, which was 400 meters. And that was what they determined was a level of fitness. So when they did that, they looked at patients who couldn't achieve it versus those who did achieve it. And those who could not had an increased risk of postoperative complications, 61% versus 21%, with at least one complication within 30 days. And so that means that prehabilitation can actually be sort of the ultimate frailty test. So if patients are not able to be prehabilitated, then that means maybe they should have adapted care. Maybe they should have that colostomy instead of the low anterior resection. So this is from the same article in JCO that came out earlier this year, looking at how do we actually implement these into everyday practices. And this is what we came up with for prehabilitation. So this is how you can focus into implementing a prehabilitation program into your practice when we know that it's not perfect and not everybody has a treadmill and an exercise physiologist to do prehabilitation. So first of all, we can consider medical optimization before surgery as part of prehabilitation. So a lot of times people think of that as separate, and we'll talk about that on the next slide as well. But it can also all be integrated. So if you have existing resources where somebody's optimizing your patients or maybe quote unquote clearing them before surgery, maybe you can use some of those resources to optimize them for prehabilitation also. You can consider using preoperative screening clinics to integrate aspects of a prehabilitation program. You can evaluate and optimize nutritional health in consultation with a nutritionist when possible. You can assess mobility. So again, the timed up and go is a pretty easy one that almost anybody can do. You can do in-home based or in-hospital based optimization. So especially with COVID, we've started doing the evaluation and the treatment of physical therapy at home. So instead of having to have a physical therapist in the office, which is sometimes costly, you can do that evaluation at home. You can include formal exercises or regimens and the use of fitness trackers. So a lot of times Fitbits or the pedometers can be really helpful. And then again, you can repeat the test. So if you do a timed up and go and they're abnormal and they don't get to normal, then again, maybe that's somebody you should be doing adaptive care for. You can identify depression, anxiety, and social support needs. And a lot of times that can be done also with the patient's PCP. So if you send them for quote unquote medical clearance, maybe you can ask them to evaluate for the other aspects that are necessary for prehabilitation. And then you can tailor the interventions. And so some patients maybe need a week or even less to be optimized. Other patients maybe need 8 weeks. And so as long as they don't have a nearly obstructing cancer, perhaps you can space things out a bit more to be able to get them to be fully optimized. And then this was another sort of model that was described by the group in McGill, talking about how we can integrate the preoperative clinic with the prehabilitation clinic. So we can use a lot of the same resources, and we should be thinking about optimization and not necessarily quote unquote clearance for surgery. So when the patients are medically optimized and also functionally optimized, now they're cleared for surgery. Next is geriatric co-management. So this is a brilliant study out of Memorial where they just looked at patients who were 75 and older, and they had surgeon selected referrals to the geriatric surgery service. So it was patients who were going to have at least 1 day of hospital length of stay, and they were going to have surgery within 2 months. So they studied 1,800 patients. 1,000 of them were in the geriatric co-management group, and then about 800 in the surgery management group. And again, this was self-selected by the surgeons. So you would think that the surgeons would select the patients that by their eyeball test were more frail to go to the co-management group versus the surgery management group. And again, the whole cohort mortality is 6.7%. But if you look at the surgery management group, it's 10.5%. And the geriatric co-management group, it's 3.5%. So you can see that there's a greater than 50% chance of, or 50% lower incidence of 90-day mortality following cancer surgery. And the authors sort of raised some questions about why that was and what maybe they were doing differently. When you have a geriatric specialist, you can identify geriatric specific comorbidities more easily. So you can identify falls, you can identify delirium before it becomes clinically significant. And the same was true with supportive services. So they noticed that patients who were geriatrically co-managed had more incidence of utilization of physical therapy, occupational therapy, and social work. When we talk about co-management, I think we should also talk about palliative care. So we know that we're not doing the best job of palliative care. There's a lot of stigma around it in the community, in patients, and a lot of times in care teams. And so what happens is that we know that older adults experience higher rates of unwanted invasive procedures following a postoperative complication. So there's less focus on comfort and quality of life, even if somebody's already is having a bad outcome and is clearly going to have a bad outcome going forward. And even in the presence of advanced directives, patient preferences are frequently inaccurately recorded or even overlooked. So we should be thinking about patients' goals and wishes, and we should be thinking about introducing palliative care early. At Penn, when I started a prehabilitation program, the only place where they had resources with physical therapy and nutrition and a multidisciplinary team that was already in place was in the cancer center under the palliative care or supportive care group. And I had a little bit of trouble at the beginning getting patients to go to the palliative care clinic because they thought, even despite all of my best efforts, that they weren't going to get surgery if they had a palliative care consult, which obviously was incorrect. But changing the minds and the attitudes of patients when they were trying to go to palliative care was a bit challenging. But then we got the option of having patients see a palliative care specialist who could talk to them about their goals and about what they wanted in addition to the rest of the team. And so then when patients did sometimes have a bad outcome, or sometimes when they had a progression of their cancer, even years later, they were plugged in with that team and they were able to get the benefit of having that relationship. So I am a really big proponent for early palliative care, and I have really not been disappointed at all by getting palliative care early. Generally speaking, when you have really good palliative care teams, which I suspect you guys have as well, they're really sensitive and they understand that patients don't want them to come barging in and saying, hey, maybe you shouldn't have surgery, or maybe you're too frail. They sort of use their powers to understand what the patient wants. And I've been incredibly impressed with them. So once again, this is the pathway that we can implement to basically put geriatric care at the forefront of any colorectal surgery practice. So you guys are all going to go all across the country, and you're going to have practices that are all different kinds, and you can implement geriatric care into all of them. And we're all going to be seeing geriatric patients for the entirety of our career. And so you guys really are the future to hopefully improve care for these patients. So now we should talk about functional recovery, the end goal of the pathway. So we undertook the geriatric assessment, the GO-SAFE study, where we looked at patients in the real world. There were more than 1,000 patients from 26 centers. And we looked at the primary outcome of quality of life. And we use this EQ5D3L. So basically that means there's a 3-point scale on 5 domains, which were mobility, self-care, usual activities, pain, discomfort, and anxiety, depression. And we looked at that at 3 months and 6 months. We also looked at functional recovery using 3 domains that we'll go into, but that was the secondary outcome of the study. So when we look at the demographics, we can see that our median age range was 78, but then we also had ages 70 to 95 when we looked at the entire cohort. We had 115 patients who were older than 85 undergoing major cancer surgery. Of the cohort, about 50% was living home independently and less than 50% with a caregiver, but you can see less than 1% were living in any kind of residential care or nursing home status. When we look at previous delirium, 5% of the population had that, and about almost 10% had had a fall in the past. This is an interesting study that I wanted to bring up because we did a bunch of frailty tests so that we could look at them pre-op and post-op as part of the functional recovery. And we found out that it was sort of all over the map of what tests describe patients as being frail. So if you look at the G8, then 68.4% of the population was frail, but only 8.1% if you looked at the ADL. ASA was about 50-50, the ECOG 15. Over here on the timed up and go, you can see that it was only 5.4%. So we didn't really know what to make of that because, again, if you use all these different tools, you're going to find different amounts of patients who are frail. And again, that doesn't really matter as much as long as you have some kind of way to get them screened further by a geriatric practitioner if they're frail. But it just shows us that we don't have sort of the optimal frailty screening tool, at least at this point. So when we looked at quality of life, this is again, this EQ5D3L. And this is where we looked at the basically rating of all of these different metrics of their quality of life. So all of the metrics basically took a hit for mobility, self-care, and usual activities, took a hit at 3 months, but then nearly rebounded at 6. When we look at pain and anxiety though, they actually improved. They improved from pre-op to 3 months to 6 months for both domains. So you're actually able to improve that because a lot of times their pain or their anxiety and depression is coming from the cancer itself. And this is really interesting. This is the functional recovery data. So this is looking at and when we talked about functional recovery, we used 3 things, which was the activities of daily living, the timed up and go, and the mini cog. So we saw that if we looked at the entire cohort, 26% of patients had recovery in all 3 domains, 43% in 2 out of 3, and then 31% had a decline. So they had a decline in them all. But if you looked at the patients who had more than one complication, then you only get 30% functionally recovered, and almost 2/3 of the population was not able to recover because of the complication. And that's where we think prehabilitation comes in, trying to optimize patients before surgery, decrease the chance that they have a complication so that they can fully recover. And this is the colorectal cohort alone. So you can see again, we actually in the colorectal cohort, we had 71% of patients who were able to fully functionally recover, but that dropped to 52% when we had more than one complication, or sorry, 1 or more complications. So again, complications of course affect patients' quality of life and their ability to recover. And so once again, this is the pathway that we talk about with implementing with the goal of functional recovery. And I just want to point you guys to a couple of publications that have come out in the last year. One is the compendium that we published in DCR looking at how to establish a geriatric program. So it includes information on what's important in the program, but then also how to make a business case to talk to your business director about hiring a physical therapist or a nutritionist, or even oftentimes a geriatrician. You can make the case by how much volume you have of colorectal surgery patients, how that is expanding, and then how you can save money by improving length of stay, improving complications. The AHRQ publishes data on how much each complication costs. So if you look at your complication rate and then look at what the potential benefit is with your program, then you can make a pretty compelling case for establishing a geriatric program. And that's all laid out in that publication. And then after about a year and a half, we have a clinical practice guideline coming out on frailty. It's under review in DCR now, so it should be hopefully coming out very soon. And hopefully that will help you guys as well as you start your practice to kind of figure out what's important and how to implement it in your own practice. The big thing is figuring out what resources you have, because you might walk into a program where they already have a geriatrician, they have a really well-established program, and there's not much that you need to do. But you may walk in somewhere where they really have little to nothing, and then you can incrementally implement it based on the JCO publication that we discussed, as well as the clinical practice guidelines. And then I just want to take a second to talk about the geriatrics task force. We're trying to transition into a committee, so I hope we'll have even more resources going forward. But a lot of the work in ASCRS is being done by this task force, and we would love to have more members and to collaborate with you all. So please keep us in mind. I know when you finish your training and you come out and you start your practice, there's a lot of competing interests and there's a lot of things to do, but we're happy to support you in any way that we can. And with that being said, I have my email and my Twitter handle here. So please, reach out at any point if I can do anything to support you guys as you finish up your training and start your practices.
Thank you so much, Dr. Saur. That was
a
great talk. I think that there are a couple questions in the chat box. I'll pull that up. First one is, what age do you stop giving patients gabapentin?
Yeah, I mean, that's like the ultimate question, right? Is like, what age is geriatric? I would say that, I would think about it at 70. A lot of times in geriatric studies, we start at 65 because that's the Medicare age. And so it's sort of easier to use that as a cutoff when you look at Medicare databases. But I think 70, 75, even 80 is probably a reasonable cutoff for something like that. But I would start considering it at age 70. And then, again, everything can be patient-centered. So if they have no history of delirium, if you've done a mini cog and they don't have any cognitive impairment and they're otherwise stable and they're having a lot of pain, you can certainly think about adding on gabapentin as an adjunct. But I think that in general, in patients over 70, I don't use it.
Okay. Another question says, great talk. At my former program, we had a geriatric trauma service to which all those greater than 65 were admitted and received appropriate management dedicated to the elderly. One interesting aspect was that those undergoing surgery were admitted to tele for 24 hours after surgery to preemptively monitor for complications such as post-op fluid shifts, delirium falls, etc., oftentimes missed on med-surg floor. Is there utility for this vigilance in colorectal surgery?
Yeah, that's a great question. Yeah, I mean, I think that is a very reasonable thing to do. I mean, I think the issue is like, what is the timeline? So is it 24 hours? Is it 48 hours? I'm not really sure what the exact amount of time is. It's probably, again, needs to be patient specific, but I think that that's a great point. I mean, we don't automatically put our geriatric patients on telemetry, but I think especially in those that you're worried about with a history of any heart issues, any renal issues, I think that that's a great idea. And more importantly, probably is having a geriatrician or somebody with geriatrics expertise to help manage them. Because again, if you need somebody to kind of be looking at delirium, falls, like those kinds of things through a lens different than a surgeon. Some surgeons are really good at, using multidisciplinary care. But I think we all have a different focus. And so the biggest advice I can give is find somebody with a geriatrics expertise. So that could be a PCP, that could be a geriatrician, that could be a nurse practitioner, somebody in your program to be able to kind of help you to take care of these patients.
If you are getting a geriatrician or their PCP involved preoperatively or through your pathway, you have identified them as somebody that should be optimized from a frailty standpoint, does that automatically trigger an inpatient, either geriatrics or hospitalist consult as well for those patients post-operatively?
So it doesn't automatically trigger it for us. So what we do is the geriatrician, or in my case, we have a geriatric nurse practitioner who runs our program. So she will do her entire comprehensive geriatric assessment, and then she'll come up with the individualized pathway for our patients. So it might be that they need nutrition optimization and PT, or it might be that they just need the nutrition or they just need the PT. Maybe they need social support. Maybe they need, their daughter to come in from Atlanta to stay with them after the surgery, something like this. So whatever the intervention is, they also put in there if the patient would benefit from geriatric co-management. So if anybody has abnormalities on any of their screening tools, essentially they're doing co-management. So the patients that are most vulnerable and frail, we flag, but not every patient who comes to the clinic.
And with it being that individualized, do you have any sort of blanket prehab, even removed just from the geriatric population, but anything that you do across the board as prehab for patients? And I guess the thing I'm thinking of right now is like even incentive spirometry, some small intervention where it's not, not diabetes optimization or nutrition optimization, but just small interventions that are maybe not proven, but anecdotally you've seen have been beneficial to the population.
Yeah. So if somebody doesn't do a formal prehab or even formal PT, somebody comes into my office, let's say, and they're super fit, I still tell them to do 20 minutes of increased exercise from their baseline 3 times a week, because that has been shown to improve postoperative outcomes, even if somebody is already fit. So that's the one thing that I always do. And, we don't have a perfect nutrition marker in the GoSafe study. We use the nutrition assessment tool, but it's really not perfect. I mean, nothing is. And we know that albumin and prealbumin, if you talk to a dietitian, they'll say, "Ugh, those are terrible. They're not very accurate. You need to be looking at micronutrients and doing all of these things, which are sort of difficult in clinical practice." So I don't think we have the perfect nutrition tool yet. So I still use albumin and prealbumin and weight loss as sort of rough metrics, but then I do the same thing. I mean, we have a pathway here at Penn where we basically just give the patients the optimal protein intake. And so I just have patients do that regardless of if they're undernourished or normally nourished, because I feel like it can't hurt to have more protein right before surgery. There's a bunch of products too that are coming out with some kind of ideal blend of protein and other micronutrients, and also sometimes there's better information or better nutrients for the microbiota. There's all these different things coming out that I think potentially will be helpful going forward. But right now we're just doing simple protein supplementation. But I think those are the 2 things that I try to do the most.
Thank you very much. And another question came up in the chat. It says, "Thank you for going through the various screening tests for frailty. Is there one that you would recommend for us that is the simplest to do in clinic or even in the emergency department if we can?"
Yeah, so we did a study looking at emergency surgery patients, and there is this Flemish triage risk screening tool. And it's just 5 questions talking about falls, living situation, history of delirium, and also history of not living independently, and then polypharmacy. Those are the 5 questions. It's out of 6 points because the living situation is actually scored out of 2 points and the others out of 1. But it's just 5 questions, and you can ask them or you can ask their surrogate, whoever it is that's with them. And that was associated with both the length of stay, the mortality, and the discharge disposition in emergency surgical patients. So I think that one can be used in any setting. It can be used in the ER. It can certainly be used in the clinic. And it's easy. Some of the information is already in the EMR. If you're in a place with an EMR, you can implement it into the EMR. So I think that's the sort of easiest one. The only thing it doesn't have is the objective information about ambulation and also cognition. So that's why we oftentimes add the mini cog, because it's so easy and quick and it gives you so much information. And then the timed up and go also, which is just the 20 or the walking test, the 3-meter walking test, which is abnormal if it's more than 20 seconds. So oftentimes we'll add those in just so we have a little bit more objective information. But if you can only do one thing, I would do the Flemish score. We do that in our cancer center and it works pretty well. We just have the nurses do it. You could have your medical assistants or whoever does your clinic do it. And that's what we started doing at Penn as well. But I just started recently, we've implemented this PrEP program, which I explained with that pathway. And we've actually just decided to refer all patients older than 70 because it is sometimes a little bit complicated to do the Flemish score for all patients. So if you're running your clinic, you can do whatever you want. But if you're trying to implement sort of universal screening for all kinds of patients, which is what my next move is, so we're using orthopedic patients, spine patients, ENT, then it becomes a little bit complicated. But I think if you're starting your own clinic, I would use the Flemish score. It was called the Flemish triage risk screening tool. So it's the one that says FTRST if you're looking it up in the literature. And that is, I think, probably the easiest thing to do. And, I'll just take a second to say, as a trainee, I remember getting all kinds of different advice on how to negotiate and what to look for in a job. And one thing I would tell you is, when you're looking at a job, just make sure that you have appropriate support. So you want to be able to build a team that can implement whatever your goals are. So you want to have a team that can help you, answer patient phone calls and, get things approved that you need to get approved while you're trying to build your clinical practice. And having a team that's sort of like-minded and is interested in optimizing outcomes is incredibly important. So I would think about that when you start to take your job. Make sure that you have an APP, for example. Make sure that you have support for your other teammates, because that's the only way that you can really implement such a expansive program to optimize patients.
Thank you so much, Dr. Saur. That was great. And I don't see any more questions in the chat right now. And just to respect everyone's time, I think we'll call it a wrap at that one. But again, thank you so much for your time and your expertise. I really appreciate it.
Absolutely. Thank you for having me. And please do reach out if you guys have any other questions, or if I can help you even as you start your practices.
Thanks so much.